I'm Dr. John Michael Lau, and I'm going to talk about neoplasia. This is a lecture for our refreshers, and this is the overview of my lecture. So we start off with introduction. We talk about um, the definition of neoplasia, tumor nomenclature. How do we call tumors? Okay. Properties of neoplasms and hallmarks of cancer. How cancer cells are evolved, and neoplastic disorders with known DNA defects, and grading and staging. Okay, so you might be surprised in the slides that come after. They are a little bit crowded, but you can use this as your study notes. So I'm going to just emphasize the important parts of the slide, since you can always go back to it when you review. Neoplasia is the uncontrolled disorderly proliferation of cells. That's why we call it neoplasm. Okay, neo means new, plasma creation, a new creation. When you hear tumor, it doesn't really denote it doesn't really equate to neoplasia. Okay, since tumor can be an inflamed, can denote inflammation, or a growing fetus. It is called a tumor. Two basic components. You have the neoplastic cells and the supporting stroma here. So this is the neoplastic cells, and you have the stroma that surround it. Okay, neoplasms grow independently at the expense of function and vitality of the normal tissues. So how do we call tumors? So in this sense, neoplastic tumors, how do we call them? So either we classify them as benign, borderline or dysplastic, or malignant, and described according to appearance, the tissue of origin, whether it is derived from the endoderm, mesoderm, ectoderm, or the degree of differentiation. Okay, or we can also the tissue of origin can also be either epithelial or mesenchymal. Okay, so here are the different tumors that are derived from the different organs. Okay, different tissues. So if it's for epithelial, for tumors that are derived from the epithelial cells, you have these tumors. Usually they are glands. Usually they are epithelium. When it is malignant, the name assigned to it is carcinoma. Okay, when we have mesenchymal tumors, for benign, you just usually you just attach the suffix oma, but for malignant, you attach the suffix sarcoma. Of course, there are exceptions. So for example, lymphoma, it is already automatically malignant. And this is again a similar table. Okay, so mesenchymal origin, epithelial origin. So take note that aside from lymphoma, you also have seminoma as a word ending in oma, but already malignant. Okay, what else? Okay, and if it's derived from more than one neoplastic cell type, okay, and if it's derived from only one germ layer, these are the examples. Okay, so usually these are tumors that are derived from the salivary glands. You have pleomorphic adenoma. We have malignant mixed tumor of salivary gland origin. Okay, when we have tumor that is derived from more than one germ cell layer, you have a teratoma. Okay, these are derived from the gonads, from the testis, and or from the ovary. Okay, usually from the ovary. You have a mature teratoma and the immature teratoma. So here we see different tissues. You have hair, you have teeth, you have thyroid tissues. Okay. So benign tumors are tumors that have low mitotic activity. They are well differentiated, slow growing, and definitely no metastasis. However, they are harmful if compressing with other structures, usually encapsulated and usually ending with oma. Okay. We also have another classification which is special in such a way that they are tumors but they are non-neoplastic. So for example, this choristoma, this is in normal tissues found in another organ. So pancreatic choristoma, these are pancreatic tissues, normal pancreatic tissues that are found either in the stomach, wall of the stomach, or in the intestine, no? Large intestine. Hamartoma, these are tumors. These are tumor-like overgrowths that are found within the same system. So for example, bronchogenic hamartoma, you can see bronchial tissues in the trachea. But since trachea and the bronchus belong to one system, that is called a hamartoma. Okay, the same goes with hemangioma. So we have another classification before we go to malignant. Okay, dysplastic tumors. These are pre-malignant lesions. Okay, so why is it so? It is because that there are layers in the tumor that are already abnormal, yet there are also layers that are still normal. Okay, however, these tumors the, these tumors already show some degree of abnormality. Okay, but still reversible. So let me show you. So from normal, okay, you have the epithelial cells. Okay, for example, if it is a we are talking about tissues, no, derived from the epithelium. Okay, when it is dysplastic, it only involves one part, no, a one part of the epithelium. Okay, when the whole layer is involved, then it's called carcinoma in situ. Okay, when there is already breaching or invasion of the basement membrane, it is what we call as carcinoma already. When it already moves out into the bloodstream, either lymphatic, no, or hematogenous, okay, it is already called metastasis. Malignant tumors are tumors that have high mitotic activity. One property is anaplasia. Anaplasia is synonymous to poor differentiation, as indicated by the following. You have pleomorphism, different shapes, okay, hyperchromatism, increase in the nuclear density. You have increased nuclear cytoplasmic ratio. You have mitosis. You have cellular dyspolarity. Okay, that means that the cells, the nucleus of the cells are not situated in one direction. Okay, you have a prominent nucleoli. So all of these show that the malignant tumors indicate that malignant tumors are having high mitotic activity. Okay, malignant tumors either invade. Invade is by movement into an adjacent or nearby structure. Metastasis is movement to another organ. Okay, so when a tumor already metastasizes, it is automatically malignant. No? It is the most important defining characteristic of malignancy. Okay, and we have examples, no? So again, for carcinoma, generally, these are epithelial, no, in origin. For sarcoma, mesenchymal in origin. Okay. So how does cancer bring about? From a normal cell, you have damage in the DNA, whether environmental, okay, or uh, or a mutation, okay, and the failure of DNA repair. You have mutations in the genome of the somatic cells, okay. You have activation of the oncogenes as well as inactivation of the tumor suppressor genes, okay. These alterations in the genes regulating apoptosis, these are also tumor suppressor genes, okay, leading to expansion, clonal expansion, okay. These are cells that uh, that are that look alike, okay. And furthermore, you have angiogenesis that bring about growth of this tumor, additional mutation, escape from immune cells, okay. Thus, you have tumor progression, then invasion down to invasion and metastasis. So properties of neoplasms, okay. Number one, monoclonality, invasion and metastasis, and other clinical manifestations of malignancy. So monoclonality just means that the origin is just a single precursor cell. We have markers for clonality, okay. So if in G6PD, okay, if the allele for G6PD is homozygous, okay. So since it's X-linked, no, both alleles are attached to the X chromosome, okay. So that presents a monoclonal tumor, okay. Next, if this a human androgen receptor gene, okay, when if it is monoclonal, it presents with the same methylation pattern, okay. When tumors present with a translocation, certain class translocation between from one chromosome to another, it is also an indicator for clonality, such as in Burkitt's lymphoma, okay. However, in lymphoid malignancies, we also have other indicators for clonality, such as in B cell tumors, such as the kind of immunoglobulins that it produces. So for it to be monoclonal, it has to produce just either kappa or lambda chain, okay. And also the same gene rearrangement for T cell tumors. If it presents with the same antigen, okay, for example, is CD4 antigen, okay, that is monoclonal. If it's a CD8 antigen that is attached to suppressor and cytotoxic T cells, that is monoclonal, okay. And also the same T cell receptor gene rearrangement, the same pattern. So invasion and metastasis, the difference is that invasion is movement of abnormal of tissues into the adjacent tissues, okay. It's just nearby, okay. There's no basement membrane penetration, not a metastasis. However, in metastasis, you have implantation in distal sites, okay. So what are the steps? So the tumor grows, okay. It invades the basement membrane and goes into the lymphatics or the blood. You have and it is transported in via lymphatics in the blood, okay. And the tumor arrests in the target tissue, and it overcomes the different immune cells that surround the target tissue, and implantation. Okay. Again, for carcinoma, the usual route of spread is lymphatic, except for 4. Okay, so you will know later in the next slide. For sarcoma, the usual route of spread is hematogenous, or through the blood vessels. The usual sites of metastasis are the following. Okay, basically it's just liver, brain, bone, and the lungs. Okay, so the tumor progression is really dependent on the oncogenes and the tumor suppressor genes that are involved. Again, carcinomas spread via lymphatics, sarcomas spread hematogenously. Okay, but there are 4 carcinomas that route hematogenously. So follicular, thyroid carcinoma, choriocarcinoma, renal cell carcinoma, and hepatocellular carcinoma. Okay, and the common sites of metastasis are the bone, liver, lung, and brain. Okay, so just read on the usual primary tumor where this metastatic CA come from are indicated. Usually these are organs that are just nearby, no? For example, the most common site of metastasis of prostate CA is bone. Okay, the bone, the pelvis, okay, the femur. Okay, and these are illustrations or pictures of organs that have metastatic CA, and you see a lot of different small tumors. Okay, so what are the other clinical manifestations of malignancy? Clinically, you see cachexia, okay, or muscle wasting. So this is a weakness, weight loss, anorexia, anemia, infection, hypermetabolism mediated by cachectin or the TNF alpha. Secondly, another clinical manifestation of malignancy, especially when the tumor that is malignant is an endocrine tumor, or a tumor involving an endocrine gland. Okay, so are the following. Okay, so for example, a pituitary tumor, of course, no, it will produce hormones that will lead to abnormalities. Okay, so for pituitary tumors, prolactinoma, amenorrhea, somatropic or acidophilic adenoma leads to gigantism. Corticotropic basophilic adenoma leads to Cushing's disease. Okay, so for example, this one also, the granulosa theca cell tumor leads to hyperestrenism. For HMOL, you have increased HCG production. Next is paraneoplastic syndromes. This is a syndrome that in which a tumor produces hormones that mimic certain endocrine problems. So for example, the small cell lung carcinoma produces hormones that are very similar to ACTH, okay, mimicking Cushing's syndrome. For example, this renal tumors, okay, it produces erythropoietin, okay, that lead to polycythemia. Okay, for example, for neurologic abnormalities, okay, when there is cerebral degeneration because of a certain tumor, you have a clinical manifestation of dementia. For peripheral neuropathies, tumors that lead to peripheral neuropathies, you have pain and decreased sensation. Okay, for visceral malignancies, okay, you can see acanthosis nigricans No? If you take note, acanthosis nigricans is a manifestation of hyperinsulinemia. Okay, and also, how do we say this? A lesser Trelat sign, no? A sudden appearance of seborrheic keratosis. Coagulation abnormalities. Okay, when a person has pancreatic CA, you this person having pancreatic CA has this trousseau phenomenon, wherein there is a abnormality in the platelet and in the coagulation cascade, leading to migratory thrombophlebitis. And many cancers lead to DIC, no? Disseminated intravascular coagulation. And these are other examples of paraneoplastic syndrome. So for example, this squamous cell carcinoma of the lung, okay, will lead to hypercalcemia because of a production of parathyroid hormone. Okay, and these are other examples. You can always go through them. Okay, next is oncofetal antigens, no, or what we call as serum tumor markers. Okay, so these are proteins that are normally produced in fetal life. However, they are produced in neoplastic cells. One example is the carcinoembryonic antigen by the colon CA, AFP, or the alpha-fetoprotein by hepatocellular carcinoma, and other examples as well. Another is HCG by hydatidiform mole, okay? CA19-9 by pancreatic adenocarcinoma. CA125, ovarian CA. And you can always PSA, okay, produced by prostate cancer. Okay, you can always go through these examples in your study. What are the hallmarks of cancer? Basically, we can classify these factors into factors that promote the growth of the cancer cells. That is from 1 to 6, no? Growth of signal self-sufficiency. So, involving oncogenes, anti-growth signal insensitivity, involving the tumor suppressor cells, tumor suppressor genes, rather, evasion of apoptosis, again by tumor suppressor genes, limitless replicative potential by stopping the function of telomeres. Remember telomeres, okay? Sustained angiogenesis by activation of the vascular endothelial growth factor receptor. Warburg effect, wherein the metabolism of cells is shifted into glycolysis, thereby feeding the neoplastic cells. Okay. Next is immune evasion, wherein the cells, whether the cells are not really recognized by immune cells, no, the tumor is not really recognized by the immune cells, or the immune cells themselves, okay, do not have the capacity to destroy these tumor cells. Okay, then invasion and metastasis. So you can always review. So what I just mentioned to you is indicated here. Carcinogenesis. How is cancer brought about? Okay. Before I tell you about a carcinogenesis, let me talk about field cancerization. It is when a certain carcinogen, no, carcinogen is focused on in a location of a number of cells, okay, leading to premalignancy and finally malignancies. For example, when you have exposure to tobacco smoke on the head and neck, okay, so it will evolve into a cancer. Or for example, UV radiation, consistent exposure of the skin to UV radiation, Okay, it will lead to skin cancer. And another is exposure of the bladder, okay, by to urinary carcinogens will lead to bladder cancer. Okay, so let's go first to epidemiology. The most common cancer is skin cancer. Okay, however, in morbidity among males, the number one is prostate CA. For females, number one is breast CA. For um, cancer mortality, uh, it's it's lung CA for males, and the same lung CA for females. Okay, so it's just a number two in morbidity becomes number one in mortality. Chemical carcinogenesis. There are two types of carcinogens, whether it is a direct reacting carcinogen. A direct reacting carcinogen doesn't need to be metabolized to another form in order for it to be carcinogenic. It is directly acting. For indirect reacting carcinogen, it has to be metabolically converted to a ultimate carcinogen, such as this example. Naphthylamine glucuronide is converted by glucuronidase to naphthylamine. Okay, and the stages of carcinogenesis involve initiation, wherein the cell interacts with the carcinogen, and promotion. Promotion doesn't need a carcinogen, but a non-carcinogenic promoter that enhances carcinogenicity. So for example, 4-bol esters reacting with the membrane receptors that activate cell replication. And these are the different chemicals that cause these certain malignancies. Okay, for smoking, of course, no, carcinoma of the lung, carcinoma. Smoking, it can be carcinoma of any organ. In fact, no. So it can also lead to gastric CA, bladder CA, okay, tongue CA, okay, UV radiation, squamous cell carcinoma. Asbestosis lead to carcinoma of the lung, and for this low fiber diet lead to adenocarcinoma of the colon. High fat diet, breast carcinoma. Again, aflatoxin lead to hepatocellular carcinoma. Polyvinyl chloride or the PVCs, okay, cause hepatic angiosarcoma. For diethylstilbestrol, it's when if the mother takes in this hormone, okay, it will lead to clear cell puts the daughters or the daughters of the mother to a risk for clear cell adenocarcinoma of the vagina, and down the line. So many examples. Okay, you can always read on those. Next is UV radiation, okay, and that's just found in sunlight, no. So when you have prolonged exposure to sunlight, more than 20 minutes, it will lead to a risk for skin CA. Okay, why? Because it promotes the formation of a thymine dimer. Okay, that's why in cases of Xenoderma pigmentosum, wherein there is a there is a failure in DNA repair, okay, so that the thymine dimers persist, okay, you will have a surely skin CA. Okay, next is ionizing radiation, wherein for example, radiologists, they are very prone to skin CA and myeloid leukemia. Uranium miners, very prone to lung CA. head and neck radiation treatment for thyroid CA. This atomic blasts lead to myeloid leukemias, whether acute and chronic. And radium watchdial workers lead to osteosarcoma. So viral carcinogenesis. There are also carcinogens that come from viruses. Such two types of viruses. We have DNA virus and the retroviruses. So DNA viruses, they are integrated into the human genome by themselves. However, for retroviruses, it is a RNA, okay, that becomes DNA by the action of reverse transcriptase, and the DNA becomes incorporated into the human genome. Okay, so viral oncogenes, okay, from these viruses, okay, is denoted by a 3-letter. So starting with a V and 3-letter. So these are oncogenes that are derived from the viruses. Okay. So for example, these are the viruses themselves, no? So for example, this human herpes virus, okay, leading to Kaposi sarcoma. This H. pylori is not a virus but a bacteria, okay, leading to gastric CA. HPV, especially 16 strain 6 time type 16 and 18, leads to cervical CA. Okay, and these are other examples as well. Schistosoma hematobium leads to squamous cell bladder cancer. And this is the viral oncogenes that we mentioned a while ago. Okay, these are incorporated into the human genome, causing carcinogenesis. So next are oncogenes and tumor suppressor genes, as well as the gene products of these genes, no, of oncogenes. So number one, oncogene protein products such as P21, which is a RAS. No? RAS is the oncogene. The product of it is P21. Okay, when GTP binds to P21, it activates the enzyme GTPase to activate signal transduction, causing abnormalities in the cellular behavior, causing proliferation. Okay. Next is the PP60, which is a oncogene product of Roux sarcoma virus. Okay, and it activates the enzyme tyrosine kinase. Other examples also activating the tyrosine kinase. We also have nuclear proteins. Okay. So we mentioned about viral oncogenes. Now we go to oncogenes or proto-oncogenes, activation of proto-oncogenes to oncogenes. Okay. So we have promoter insertion. Okay, wherein you have insertion of retroviral promoter sequences into the human genome, increases nearby human oncogene expression. Okay. Next is point mutations. Okay, you have a mutation in the gene. Okay. So for example, in the RAS gene, a mutation in the RAS gene by a single nucleotide change. Next is chromosomal translocation. Okay, so for example, you have these genes, okay, leading to a translocation of this chromosome, leading to these malignancies. And you also have oncogene amplification, wherein the tumor produces multiple DNA copies of the oncogene. Okay. So for example, neuroblastoma, the oncogene involved is NMIC. For some breast CA, the oncogene involved is the HER2-neu or ERBB2. These are the examples of oncogenes. Okay. So for example, ERBB1, lung adenocarcinoma, ERBB2, that's breast carcinoma and gastric. RET oncogene, okay, that lead to multiple endocrine neoplasia. BCR-ABL, okay, lead to CML, chronic myeloid leukemia. And what else? KRAS leads to colorectal CA, adenocarcinoma. Okay. Next is, we mentioned about oncogenes, proto-oncogenes. Now we mentioned about cancer suppressor genes. Okay. So these are genes that, or tumor suppressor genes. These are genes that when present, suppress the tumor, but when absent, it promotes proliferation or persistence of the tumor. For cancer to proceed, okay, both tumor suppressor genes have to be mutated, have to be inactivated. So this is what is known as the two-hit hypothesis of Knudson. So what are the examples of tumor suppressor genes? So RB, retinoblastoma, P53, tumor suppressor gene. We have many, okay? Breast tumors, brain tumors, WT, Wilms tumor, APC. You find this in adenocarcinoma of the colon, BRCA1 and 2, breast CA. And other examples as well. Can always go through these examples. And these are the other neoplastic disorders with known DNA defects. So for this neurofibromatosis, you have a mutation in the NF1TS tumor suppressor gene, leading to this syndrome, neurofibroma, cafe au lait, or coffee-like spots, no? With increased risk of fibrosarcoma, multiple endocrine neoplasia, okay, mutation of the RET proto-oncogene, leading to abnormalities in the carcinoma in the thyroid, in the parathyroid, and pheochromocytoma. This disorder, the Lynch syndrome or non-polyposis CA, okay, will eventually lead to colorectal tumors, okay, because of this mutation of these genes. And again, xenoderma pigmentosum, okay, because of the difficulty of repair of these thymine dimers, leads to increased risk for skin cancer. So again, what's the difference between grading and staging? Grading is looking into the cellular differentiation, whether it is a well differentiated or poorly differentiated. Okay. For staging, we are looking into the extent of metastasis, extent of invasion of the cancer. So for grading, we base it on biopsy, histological findings. For staging, we base it on CT scan findings, where we can assess the degree of spread of tumor cells. Okay, so I think we are done, no? So we mentioned about neoplasm, neoplasia. We were able to designate some names on certain types of tumors. Okay, so if it's benign, malignant, okay, how do we call them? And properties of neoplasms, So neoplasms are monoclonal. They invade, they metastasize. They have certain clinical manifestations. Okay, hallmarks of cancer. These are factors that promote the growth of the cancer, and we also have factors that allow the cancer to stay on, and there are also factors that allow cancer cells to move into other distant sites. Next is carcinogenesis. So we mentioned about different ways of formation of cancer cells by chemicals, by exposure to occupational hazards, by viruses, exposure to viruses. We also have certain oncogenes and tumor suppressor genes. Okay, that that when activated, or for tumor suppressor genes inactivated, okay, will promote CA. And we also focused on some neoplastic or cancers or disorders that have known DNA defects. For grading and staging, we have successfully differentiated these two terms. Okay, so I think that's it. So you go back to your books and to your review, to your review notes, and don't forget to answer practice questions so that you'll be able to master answering board exam type questions. Thank you so much and have a great day.